Hi, it's John Marshall. I'm back to give you some update from UEW and ACG related to functional gastrointestinal disorders. And I've chosen a few abstracts which I think give you a bit of novel insight into a variety of functional conditions. The first abstract I'll present is this one from Sood et al. This is part of Alex Ford's group in the UK, who conducted a meta-analysis, systematic literature review of diagnostic criteria for the irritable bowel syndrome. And as you know, there are a variety of different diagnostic criteria out there in the literature, largely related to symptom clusters such as Manning and Rome. But there are also some biomarker panels in development. And of course, all of us in practice don't just use symptoms, we also use some results from blood work as well as the patient demographics themselves. If you look down the column in this table showing positive likelihood ratios, that is how much more likely each of these criteria makes a diagnosis of irritable bowel syndrome, you can see that something called fecal VOM, or volatile organic metabolites, has a very strong positive likelihood ratio. This is really a novel tool looking at metabolic products within the stool sample. It's not something that's widely available, still needs to be replicated, but does hold some potential value for the future. If you look at where the highest positive likelihood ratios are otherwise in this table, you can see that the bottom two rows statistical models that reflect a combination of symptoms, biomarkers, laboratory results, in addition to psychometric markers, really perform best. So I think what this abstract tells us is that we shouldn't rely only on symptoms to diagnose irritable bowel syndrome among our patients with chronic symptoms. We should, of course, incorporate results from blood work, demographic criteria, and possibly even psychometric assessments. So I think this is a potentially useful observation. So fecal VOM are promising, but they need replication in other studies, but that IBS may be best diagnosed from a combination of these other metrics and not just relying only on symptom profiles. So staying on the subject of diagnostics, we can look at different approaches to esophageal manometry. And of course, this field is moving away from traditional esophageal manometry and the tracings that we're quite familiar with in the upper two images in this panel, towards high-resolution manometry, which produces images such as those seen in the bottom half of this slide. The left image being a normal motility study showing esophageal transit of a food bolus, and the right showing the changes that can occur in someone with achalasia. So high-resolution esophageal manometry typically has at least one manometric port every centimeter, so you get much more data and you get much more detailed images and different ways of presenting the data for interpretation. So is the high-resolution esophageal manometry actually useful as a clinical tool? It certainly produces some beautiful images, but does it improve how well we diagnose our patients? This abstract I can show you from UEW from Roman et al. Looks in fact at a randomized controlled trial comparing these two different approaches. So 245 subjects at 6 centimeters. Centers were randomized to either undergo high-resolution manometry or conventional manometry. Now, in the randomization process, the conventional manometric group was slightly older, but there were no other differences between the two arms of this study. The key findings were that the high-resolution manometric procedure, in fact, took much less time, both for acquisition of the data itself and for the subsequent analysis of the data, so 15 minutes overall compared to 31 minutes. And interesting that the high-resolution manometry also had a higher diagnostic yield. So all but 3% of the patients in the HRM arm, in fact, were assigned a diagnosis. Among the patients who were not diagnosed by either conventional or high-resolution manometry, the undiagnosed patients in the conventional arm tended to have more severe dysphagia. So there's a sense that they left a particularly unwell group of patients undiagnosed. And with subsequent follow-up, it was the diagnosis assigned by high-resolution manometry was more likely to be confirmed than that was assigned by conventional manometry, although that p-value did not reach statistical significance. So the conclusion of these authors was that high-resolution manometry may well be superior to conventional manometry for the diagnosis of motility disorders, may allow an earlier diagnosis, and certainly may allow a faster diagnosis, which speaks to the efficiency of running a motility unit. And certainly at our center, we've switched to the use of the high-resolution manometric technique. So staying with the upper gastrointestinal tract, this was an interesting abstract from the Barcelona group from Aspiris et al., looking at rumination disorder diagnosed by Rome criteria. It's a relatively uncommon presentation, but a challenging one to manage. And I have to say that biofeedback is underappreciated and certainly underfunded across Canada. So these authors took a group of 24 subjects who fulfilled the Rome criteria for rumination syndrome and essentially looked at the value and the impact of biofeedback. They performed abdominal thoracic muscle EMG and in three sessions over 10 days showed the EMG recordings to these subjects. They're randomized then to two different interventions. Those in the true intervention arm actually received biofeedback, that is specific instruction while watching these EMG recordings and how to control various muscle activities. And the control group was given simethicone simply as a placebo and allowed to watch the EMG recordings. And the results were significant. Among, if you looked at intercostal muscle activity on EMG, subjects who were given true biofeedback were far more likely to show a reduction in intercostal activity, 46% versus only 1% of the control group. The anterior wall activity was reduced by 50% in the intervention group compared to really no change in the control group. And the number of regurgitation episodes was reduced by almost 3/4 in the intervention group compared to almost not at all in the control group. So I think these are highly significant results and really suggest that biofeedback-guided control of abdominal thoracic muscle activity can be an effective therapy for rumination. I think it's a syndrome for which we really have no other effective therapy, and this really needs more study, and hopefully these sorts of techniques will become more available across Canada in the future. Well, a hot topic certainly in gastroenterology right now is use of FODMAP diet, these fermentable, oligo, monosaccharides, and polyol diets. Diets that try to restrict intake of a large list of food products that contain these compounds with the hopes of alleviating a number of chronic gastrointestinal symptoms, including bloating, which is, as many of you know, very difficult to manage. This is one of many images out there on the internet that help patients in choosing between high FODMAP and low FODMAP containing foods. Many of you will remember this clinical trial that was published in Gastroenterology earlier this year, which took a cohort of patients in Australia with irritable bowel syndrome and randomized them to either continue a traditional Australian diet, whatever that might be, or to be randomized to an intervention with a low FODMAP diet. And certainly if you look at the overall symptom severity on the left, there's a highly significant difference in symptom severity with improvement in the FODMAP group compared to the conventional Australian diet. And if you looked at fermentation profiles, breath hydrogen is much lower in the subjects randomized to receive a low FODMAP diet. So this is certainly very encouraging and certainly led many of us in practice to propose FODMAP diets to our patients with irritable bowel syndrome. I think it's worth pointing out that this year's UEGW meeting, a Swedish study was presented, which is another randomized controlled trial looking at the effect of a low FODMAP diet. In this case, 82 subjects with IBS diagnosed by Rome 3 criteria at 3 Swedish centers were randomized to either a low FODMAP diet or what they consider traditional dietary advice for patients with irritable bowel syndrome. And it's difficult to read at the bottom, but the traditional dietary advice given to patients with IBS in Sweden includes eating small frequent meals, peeling and dividing food into pieces, chewing well, boiling food where possible, reducing the intake of fat and spice, also reducing the intake of legumes, onions, alcohol, and caffeine, avoiding carbonated beverages and sweeteners, and particularly sweeteners that end with OL, such as sorbitol, and also distributing fiber intake evenly over the day. So patients were randomized to either that advice or a low FODMAP advice for 4 weeks. They were assessed using this IBS severity scoring system with a minimum entry criterion of a score of 175 and response being defined as a drop of at least 50 points on that score. It was single blind. Certainly the subjects knew which diet they were eating, but those who assessed outcomes were kept blind. 65 subjects completed the study. There were some screen failures in some patients who didn't follow through with the protocol. But the response was really no different between the two treatment arms. So the response was seen in 56% of those on low FODMAP versus 52% on the traditional diet. Really no difference in individual symptom changes, although there's a trend towards larger reduction in reported distension in those on the traditional diet, but also no difference when subjects were stratified by the severity of their IBS. So really, this study actually concluded that traditional dietary advice, at least that advice given in the Swedish center, was no different from a low FODMAP diet in improving IBS symptoms. So it may be that individual patients benefit from different forms of dietary advice, and I think that dietary modification certainly has a role, but low FODMAP may not be the answer for everyone.